Hi, I'm Casey Cosgrove, and it's an absolute pleasure to be joining you all today for this wonderful conference. Today, I'm going to be speaking about a very exciting topic in the area of cancer, which are liquid biopsies. So the title of our presentation is going to be, what are liquid biopsies and what is their role in screening and treatment of gynecologic cancers? Once again, my name is Casey Cosgrove, and I'm an assistant professor in gynecologic oncology at the Ohio State University Comprehensive Cancer Center, James Cancer Hospital. And I have a passion for taking care of women with gynecologic cancers. And this is a topic that's really exciting within the field of oncology. And I look forward to sharing some exciting information with you about the potential applications for this technology in the treatment, management, screening, and impact that we can have in the cancer community. I have no relevant financial disclosures related to the material that we'll be presenting today. We have several important objectives that we're going to go over. First and foremost is going to be describing what liquid biopsies are. And our conversation today, while I'm a gynecologic oncologist, a lot of what we're talking about is going to be liquid biopsies in general. We're also going to discuss the advantages and disadvantages of liquid biopsies. And then essentially, the most important is reviewing the applications of liquid biopsies in cancer care and decision-making, and also kind of where I see the field heading over the next couple of years. So to begin, what are liquid biopsies? So the definition varies. And so if we look up liquid biopsies, you're going to read a lot of different potential definitions of what they exactly are. But in general, when we talk about liquid biopsies, it's using body fluid to test for some sort of biomarker. And while we can use any body fluid, the most commonly used body fluid for liquid biopsies is blood. And blood is tested then for several different things within the liquid biopsy umbrella. The most common use when we talk about liquid biopsies are looking at cell-free DNA or circulating tumor DNA. So when you are reading something about liquid biopsies, the most likely scenario that we're going to be reading about right now, I think, is going to be blood looking at cell-free DNA or circulating tumor DNA. But there's several other things that we can also be looking at in the blood that would qualify as a liquid biopsy. Those can be like extracellular vesicles, which are like little envelopes of different genetic material that can be circulating through the body, microRNAs, circulating tumor cells, which is also an area of a lot of excitement, as well as tumor-derived metabolites. So within liquid biopsies, can be any type of liquid, most commonly blood at this point. And then lots of different things can be tested within the blood. But right now, circulating tumor DNA or cell-free DNA or circulating tumor cells are probably the majority of what we're discussing when we are reviewing liquid biopsies. One important concept with liquid biopsies is that the more stuff, whether it's any of the things that we listed above, are seen in bigger tumors, higher stage tumors, tumors that have increased cell proliferation, increased vascularity, so more circulation into tumors, as well as different tumor types. So while liquid biopsies might take an umbrella term, there's a lot of variability as to what might be occurring within different tumors and different tumor types. There's a short history of liquid biopsies. You know, this is a relatively new field within medicine, relatively new technology that we're able to utilize. But it dates back to 1948 when scientists first noted that there was DNA that was circulating through our body that wasn't within our cells. So circulating tumor DNA was first noted. And we might be aware that all our cells have DNA within it, and sometimes DNA can escape the cell and be circulating within our bloodstream. In 1977, we kind of recognized that there were higher levels of the circulating tumor DNA in cancer patients, or higher rates of circulating DNA in cancer patients, which led to some interest that maybe this could help us understand what's going on from a cancer standpoint. Within liquid biopsies, or more importantly, within circulating tumor DNA or circulating DNA or cell-free DNA, there's several applications outside of cancer that are already kind of interest or being utilized, most specifically within pregnancy. In pregnancy, cell-free DNA is currently used quite commonly, actually, in screening for aneuploidies or chromosomal aberrations like Down syndrome. We can also see higher rates and applications for circulating DNA or cell-free DNA in non-cancer diagnoses, And so this extends beyond just the oncologic community. Until the mid-2010s or so, our technology was just not adequate to make this available or make this clinically applicable for our patients that we're taking care of. And so just within the last 10 years or so, the idea of liquid biopsies in cancer care has really become a reality. These little charts on the right side show on the top, that blue line, are PubMed searches. So PubMed is where we can go get access to all the different journals and medical literature that gets published. And we can see this major uptick just within the last couple of years of people searching for, or not even searching for, but just topics on liquid biopsies. So just within the last couple of years, we've seen an explosion. And then the green lines show Google searches. And so Dr. Google showing how many people are starting to incorporate liquid biopsies in our vocabulary and researching it and looking at potential opportunities with it. We're going to start off with a clinical case, just to kind of show the first application that people are questioning whether or not liquid biopsies are going to be helpful for us in taking care of patients with cancer. So this is a 58-year-old woman who comes to see her primary care physician, and she inquires about her risk of cancer. And she asks, what can we be doing to catch cancer early? And this is a very common question. It's something that we talk about all the time with our patients, either that have had a cancer diagnosis or that have not had a cancer diagnosis. And the first thing that we have to remember is that cancer is relatively common. In fact, 1 in 3 women in their lifetime will develop an invasive cancer. The second thing that we have to understand is that we have to make sure that we are discussing the tried and true things that are already well established in not only the prevention of cancer, but early detection in cancer, and that's screening and behavioral modification. So when I'm prioritizing this particular case with a patient, I'm talking about what I know has a potential impact on catching cancer early and also management of the cancer. And those are things like mammograms, colonoscopies, pap testing, et cetera, et cetera, et cetera. So these are all screening tests looking for particular cancer types. I'm also talking about behavioral modifications that can help to prevent cancer from developing. These are things like smoking cessation, sun protection, and weight loss. And then when we're talking about any of these testing to try to catch cancer early or prevent cancer, we have to be thinking about, is what we're doing actually making a difference? And even amongst these tried and true screening tests like mammogram and pap testing, there's debates amongst the scientific community about when do we start, when do we end, how often do we have to get them? And that's because we want to make sure that we're getting the most impact from the testing that we're doing for our patients. So then the conversation shifts from kind of what we've been established to do over many, many, many years of medicine to what about liquid biopsies? So the first part of the conversation when I discuss this with patients that are looking at this for early detection or cancer prevention, things like that, is that liquid biopsies are not a replacement at this time. Liquid biopsies should be looked at as more of a complement to the way that we're already managing our patients. There's multiple applications for liquid biopsies for patient care. This includes potential for early diagnosis or diagnosis of a cancer period, monitoring their disease for a known cancer patient, and then also helping to influence potential therapeutic decision-making. There are many great strengths to liquid biopsy technology that we have to emphasize. First, it has a high sensitivity, which means it picks things up. So we can order a test that can identify something going on. It's minimally invasive and it minimizes the tissue needed. And this becomes essential, especially important for tumors or areas that are in risky locations that we can't necessarily access with our traditional means for biopsy. We may be able to get answers with liquid biopsies that we can't by biopsy tissue. Once again, if I can't get a biopsy or I can't serially or continuously be monitoring with biopsies, it also gives me a real-time answer as to what's going on in the tumor. I can perform these on a more frequent basis than sticking somebody with a needle into a risky location. And this will allow for potentially more frequent sampling to understand how the tumor or cancer is evolving over time. Liquid biopsies can be integrated with traditional management plans. So we might already have our well-established foundation of my counseling for patients, my treatment for patients, my monitoring of patients, but liquid biopsies may be able to supplement some of the deficiencies that we have in our current management of certain cancer types. The other important thing about liquid biopsies is they might be a greater representation of the overall tumor. And this gets to the concept of tumor heterogeneity. There's a little cartoon on the right side of the slide that kind of demonstrates this. So within a tumor, there's multiple different populations of cells. And so when we do a traditional biopsy, we might only be sampling one little area. For instance, in this cartoon, the green area. So I might know up-to-date information about that one area I biopsy, but a liquid biopsy allows us the opportunity to have maybe a better understanding of what's going on within the whole tumor, not only in one location, but if there were multiple tumor sites throughout the body, it might give me a better composite or global understanding of what's going on with a cancer. So there are several weaknesses of liquid biopsies, and these are things that hopefully will help be improved on as we get more comfortable with technology. Perhaps one of the biggest concerns is false positives. And one of the main reasons why we've seen some false positives is something called clonal hematopoiesis. So as any of us get older, we develop some mutations that just develop within like our blood cells. And these can be detected during a liquid biopsy as some background noise. So we may get a false positive or a call about a cancer just based off of a normal aging signature. We also might get something like a false positive, meaning that we may detect a different cancer, or a different cancer might be causing what we find on a liquid biopsy. Cost is another question. As technology improves, we hope that costs will be decreased, and as we have a better understanding about the role and how often we should be using it, we should also start seeing costs become more affordable, especially as it gets integrated into more standard practice. Reproducibility. So right now, this is such a new technology that when we have several companies that are just starting to do this, we have to make sure that across each one of these platforms, we have the similar results that are coming. Or when I get a report back, I need to be able to feel confident that that report means what I think it means. We usually need an initial diagnostic biopsy. Okay, once again, this is not a replacement. This is a complement to what we're already doing. Liquid biopsies can give us some valuable information, but they're not going to give us specific histologic features. So what things look like under the microscope, having to do with the grade of the tumor. It's not going to tell us what stage it is. And it's not going to necessarily give us the most complete replacement for the way that we're already kind of collecting our data or information about how we should be managing a cancer type. So when can we use liquid biopsies? And hypothetically, anyone, anytime could get a liquid biopsy, a blood test, send it off to a lab, and screen for cancer types, right? So this is the concept of liquid biopsies for early detection and screening of cancer. The main question that comes up with this is, are we ready for it? And what are we going to be doing with that information once it starts coming to us? Today, most of the applications and most of the discussion within the cancer community is really, once a patient has a cancer diagnosis, what application can liquid biopsy have for monitoring the disease, helping with treatment decisions, monitoring for residual disease, and evaluating earlier recurrences? Liquid biopsies also have the benefit of that potential for repeat or serial testing to understand how tumors might change over time and allow us to kind of be a little bit more precise in our management. There's some headlines over here on the right side that I took from some newspapers, and I think that these are true headlines, but they can be a little bit misleading because they don't necessarily take into the actual application of liquid biopsies. Sidestepping the biopsy with a new tool to spot cancer, that is true, but it's not going to replace biopsies completely. Certain circumstances, it can replace a biopsy, but it doesn't eliminate what we've been doing in the past for many, many years. Liquid cancer test offers hope for alternatives to painful biopsies. That is true. However, you're still probably going to need to get that initial biopsy and initial testing done that might require procedures, surgeries, et cetera, et cetera. So potentially kind of the main hope for a liquid biopsy would be, can we detect a cancer really, really, really early? And we know that if we catch cancers earlier, we might be able to influence our opportunity to cure that cancer. So usually when we talk about cancer, diagnosis is made because somebody has symptoms or because we have an established screening test that can identify cancers early. It's important to understand that not all cancers are screened for. For instance, in my world, ovarian cancer does not have a good screening test. Also, sometimes symptoms develop late in the disease process. Once again, using ovarian cancer as an example, usually, and most ovarian cancer patients present at more advanced stage because the symptoms earlier are so subtle. So liquid biopsies potentially could have the opportunity to screen for a cancer that we don't have a screening test for, but also maybe identify cancers at an earlier stage, which may influence our opportunity to cure the cancer. Liquid biopsies, therefore, might fill this gap. The problem is that liquid biopsies currently, they might not catch something. So we might get a false reassurance with a negative liquid biopsy. There's also the possibility that we could get false positives. And this happens across the whole spectrum of liquid biopsy use, is that if we get a liquid biopsy test that comes back as being positive, that's not a guarantee that something is going on. I took this data from the Galleri website, which is a company that is offering a screening test for cancer, and they call this a cancer signal detection. And so they present this right on their website very transparently, and they present data from people that were 50 to 79 that got this test, and about 1% of the individuals that they sampled had a cancer signal detected, okay? Of those, 40% received a cancer diagnosis after diagnostic evaluation. So let's think about this. This is a patient between 50 and 79. They come in, they get this test. It may come back as completely normal. That gives them reassurance. It's not a guarantee, but it's some reassurance. It may come back with a cancer signal detected. That just tells us that we need to go looking for the cancer. So they still need to get the normal procedures to evaluate for where the cancer might be coming from. They still probably are going to need to get a confirmatory biopsy to establish the diagnosis. And just because they receive that scary cancer signal detected information, it's not a guarantee that they have cancer going on too. So you can kind of see some of the scenarios where it could be challenging for patients and clinicians to say, okay, how do we incorporate this information into our day-to-day practice? There's an article that came out in June 2022. This was kind of a little bit of an editorial piece looking at some of the recent news. This was in one of the Science reports, and Science is a very well-established scientific journal. We really high impact, puts out really good scientific information. This is kind of like their a little bit report about what was going on. And what they said was the complexities are staggering. That's kind of like the headline from some major scientists within the National Cancer Institute. So last week, they report that the NCI advisors endorsed a $75 million 4-year pilot study looking at this technology to help identify early detection of cancer. And it kind of goes to show you that where the scientific community is, like, yes, we're very excited, but we need to do our due diligence to kind of best establish how this is going to fit into our practice. So when we talk about liquid biopsies, once again, for cancer detection, and we talked a little bit about this. So we talked about a patient that was completely asymptomatic, that gets a test, and we may identify a cancer signal, and those patients may have a cancer diagnosis. What happens if we use this liquid biopsy technology on patients with a known cancer diagnosis? All right. So this was data that was presented in the Annals of Oncology, and what they saw was that they tested this technology on patients with known cancer diagnosis, and about half of the patients with a known cancer diagnosis had a positive cancer signal detected. And this goes back to sensitivity, our ability to pick things up. So even with somebody that has a known cancer diagnosis, this wasn't 100% slam dunk. The other important data that came from this was that there was increased detection with the stage. So at stage 1, only 16% of cancers were identified with the liquid biopsy versus stage 4, where 90% was. And this goes back to how much tumor volume there is in the body and how much of this genetic material is being circulated through the blood to be able to be detected. And once again, when we look at liquid biopsies for early cancer detection, if we're missing those early stage cancers, then the impact that we can potentially have on cure might be lower. On the other side, a benefit of these liquid biopsies are that when I order a screening test, I'm particularly looking usually at just one type of cancer. Let's say a mammogram. I'm looking for breast cancer. But with liquid biopsy, I can kind of get a lot more bang for my buck, meaning I can screen for potentially 50 plus cancer types as opposed to just one. And so there are scenarios where potentially this can help complement kind of our tried and true screening models to look for cancers that might not have a good screening test, or for individuals that might not be able to get a list of 15 screening procedures to look for the cancer types that we have screening for. There's also differences in detection in different cancer types. Kind of going back to some of our introduction to liquid biopsies is that different cancers shed or release different amounts of this genetic material, and therefore, I might not be able to say with exact confidence that every cancer type is going to be equally evaluated with a liquid biopsy. So, summary for liquid biopsies for the diagnosis. Well, it's important to understand that it can be negative and you can still have cancer. Okay? And we saw that 50% of patients with known cancer had a negative cancer signal. It can be positive and not have cancer. We said that 1% of patients in this one study had a positive cancer signal, and about 40% of those had a confirmed cancer diagnosis once a complete diagnostic evaluation was completed. You still need to get a diagnostic workup. You still need additional testing. So liquid biopsy does not completely replace what we're doing right now to diagnose and detect cancer. And certainly this is an area of excitement to identify cancers that we might not have screened for. This is certainly an area of excitement to hopefully identify cancers at an earlier stage, especially as the technology improves. Let's move to a second case. In this case, we have a 61-year-old who recently completed their treatment for cancer. So this is not screening, not diagnosis, somebody that has a known cancer diagnosis. And a common question I get in my practice is there any cancer remaining in my body? And right now, it's a guess. I know where they started with their cancer. I know what treatment they received. I might have up-to-date imaging and blood testing. But, my hope and my assumption and my goal would be that, no, there is no cancer in the body. But can I say that for certainty, even with a bunch of negative testing? No. And residual cancer, or cancer that's remained after we've completed therapy, is probably the major cause for the cancer recurring or coming back or relapsing. This gets to the concept of subclinical. So I can't detect that there's cancer in the body, but there is cancer left. Main questions I have as a clinician is, would having that information and giving more treatment, if I knew that there was residual cancer, alter prognosis? So if I give more treatment, does that cure more patients? Does identifying cancer recurrences early, so if I know the cancers come back earlier, can I make a difference? And on the other side of things is, did we do too much treatment, right? So if I have a patient that completed one part of their cancer treatment and they have no subclinical cancer detected through a liquid biopsy, does that mean I need to complete their treatment? Do I need more treatment? So the idea can kind of go in both directions. So monitoring for residual disease is an application that we're excited about within liquid biopsies. So minimal or microscopic residual disease, things I can't pick up clinically, are probably why relapse or recurrence occurs. And there's data on circulating tumor DNA or circulating tumor cells, so liquid biopsies, that have been associated with poor outcomes in several cancer types. So we know if you start off with more circulating tumor DNA, you probably had a higher tumor burden to begin with, and those can be more challenging to achieve cure on. So if I have a patient that has undergone treatment and we still have some remaining circulating tumor DNA, circulating tumor cells, and we are worried that there's some subclinical cancer left, can we alter their trajectory of their disease by giving more treatment? So should treatment change if positive, or on the other side, should treatment change if it's negative? If there's residual disease identified through a liquid biopsy, does that mean more treatment? If there's residual disease after, let's say, a surgery, does that mean that we give treatment? So can we triage patients after an initial treatment to see if we should give more? And on the opposite side of things, if we finish up with one particular part of their treatment, let's say surgery, and there's no subclinical disease that's identified through a liquid biopsy, does that mean that we wouldn't need to do any further treatment? This is really complex. And, I think that this little diagram is to show what we're talking about. Is we start off on the left side with a cancer diagnosis, and that's identified through liquid biopsy and through our traditional testing. We get treatment. We see that the clinical response goes down as well as the subclinical response goes down. Now, if you're on the green line, we might be at a point where we're in a point to lead to cure. If we're in the red line, we might say, gosh, I don't think there's any cancer left, but liquid biopsies or something like that might tell us that there is some residual cancer. Now, the major questions and the ones that we don't have answers for amongst all cancer types is if I give more treatment at that point, does that mean I have a higher chance of getting us down to that green level? Does that mean that we have a higher chance of curing it? And also, if I incorporate treatment earlier, does it impact kind of the downstream effect of keeping the cancer away? So this is where the technology has a lot of question marks. So we may be able to identify cancer recurrences early. We may be able to identify residual cancer. The main question I have as a clinician is, if I have that information, can I make a difference by doing more or less? Monitoring for recurrence is a similar circumstance. So we're kind of talking about after we finish treatment, is there subclinical or some residual disease left on the left side? Now we're talking about somebody that we have completed treatment and I'm seeing them back for their surveillance visits every couple months. And I'm saying, okay, do I need to worry about their cancer coming back? Now, liquid biopsies can be utilized potentially as an opportunity to identify recurrences. And if we identify recurrences earlier, can we change the outcome? Certainly, if we find it earlier before somebody develops a symptom, then maybe we could prevent a symptom from developing, which is great. And this is probably very case by case and also very cancer type dependent. And so it's hard to make blanket statements off of earlier detection equals better or different treatments. But one of the main things in our practice is, what do we do with some of these asymptomatic recurrences? What type of treatments do we use? And if we had a liquid biopsy and that was the only thing that was pointing us that the cancer might be recurring, is that something that is strong enough information for us to impact their treatment decisions? And these are areas that I think are continuing to be investigated and hopefully we'll help understand at some point. Now, what I will say, and this is a fact, is that liquid biopsies in this circumstances can give us up-to-date data on the cancer, all right? So if I get a liquid biopsy and I know that somebody's cancer has come back, or I'm pretty worried that somebody's cancer has come back, that liquid biopsy is going to give me information about what that cancer is doing right now from a genetic standpoint. It's going to give me an idea about what targetable mutations, potentially new ones that have developed since the diagnosis or from our initial biopsies. It's also going to give us an understanding about resistance mechanisms or maybe why certain treatments stopped working or weren't working. And it can possibly help with our treatment decisions moving forward. So liquid biopsies for biomarkers and treatment. So since liquid biopsies universally kind of rely on some molecular testing, so if we're looking for circulating tumor DNA, we're going to be sequencing that DNA and we're going to be getting up-to-date molecular profile. And so when we think about that, that's going to give us up-to-date information about particularly precision medicine decisions. So a traditional biopsy, if we got a biopsy, would tell me, yes, the cancer's come back. And I can send that off for molecular testing to get information. But biopsies are not always possible depending on location. It doesn't address the idea about tumor heterogeneity or what the tumor is doing in different locations. And as we can see from this cartoon on the right side, we might start off with, let's say, one mutation or something that is really targetable. But as the cancer evolves, there might become 4 or 5 different profiles that we have therapies to potentially take care of the cancer with. And so, that's the area where liquid biopsies potentially could have some significant benefit in treatment decision making. So what about liquid biopsies in GYN? Fairly limited data, especially comparative to other cancer types. So let's say lung cancers, which there's a lot of information about. But there is certainly excitement. Screening, early detection, treatment decisions, response, looking at resistance mechanisms. The FDA has come out with a companion test with a liquid biopsy, looking particularly at BRCA mutations within the tumor, and that allows for applications for PARP inhibitors. In cervix, there's a lot of interest about looking at HPV specifically, and in endometrial cancer, looking at different molecular profiling for recurrence risks. So within each cancer type, there's particular questions that we're really looking at and applications that we can kind of take hold of. And so not really broad strokes here, but really kind of focusing in on particular things. I'm going to end with a particular case scenario where I think that it's going to be really important. So I'm going to say that there's limited application right now, but not zero, okay? And the clinical scenario where I think that this will impact my practice right now is a 51-year-old with advanced ovarian cancer who doesn't have adequate biopsy or no residual disease after their surgery. And I'm looking for a BRCA mutation to inform our treatment decisions with PARP inhibitor. This would be a perfect example of where a liquid biopsy in ovarian cancer care can come in. It's been a pleasure talking with you all today, and I hope you've enjoyed the presentation.